Great. Thank you, Jason. And I'd like to thank the NCRTP for inviting me. I come all the way from Ottawa. Psychology is in February. February is Psychology Month. But I don't know why psychologists chose February as Psychology Month in Canada, because it's very cold. So I choose to represent Psychology Month with this beautiful image by Monet, nice summer day. And psychology is part of a team, and the team, we are bridges. And what we are bridges in healthcare, providing healthcare, is helping bridge our patients, for example, from diagnosis through treatment, and we can be a bridge over troubled waters. Many of you, probably I'm the only psychologist in this room, so I thought many of you might be thinking, so if we have a team, why would we need a clinical health psychologist? Exactly what does a psychologist do in a hospital? So I thought I'd mention a little bit of some of the things that we're trained to do. So we're trained to conduct psychodiagnostic assessments. So basically, we see patients and we're able to do a clinical interview and administer a bunch of tests in order to make a diagnosis of depression, generalized anxiety disorder, figure out personality functioning. Personality issues are really important, not only in our patients, but in our staff. And also, the next thing that we're able to do is, based on these interviews, what we're able to do is conduct empirically validated psychotherapies to help our patients. We can do cognitive behavioral therapies, we can do interpersonal psychotherapies, and I do a lot of group psychotherapies with my patients. One of the things in the medical world that we're able to do is help our patients psychologically adjust to a new diagnosis. It can be very life-altering to get a diagnosis of a chronic long-term illness. And what we do is we help our patients psychologically adapt in terms of what are the issues related to loss. And sometimes it's loss just of your identity as a healthy human being, and you have to adapt to what does that mean now for my life. Adapting to the fact that the diagnosis may have been very traumatic. And as Carla described earlier, many people are coming to us with a lot of histories of trauma, and this new diagnosis can reactivate those old traumas and cause some symptoms like PTSD that we can help them cope with as well. And often as well, being diagnosed with a chronic long-term illness raises existential issues for people. And it's really important that then they have a chance to talk about these issues, because if they don't have a chance to talk about them, often they just disappear and don't come back for treatment. The other role that psychologists have is in doing clinical research intervention studies. We're doing a really exciting study on smoking cessation in our clinic in Ottawa, because 40 to 60% of our patients smoke, our HIV patients smoke, which is really high rates. And they're not dying of AIDS anymore because of our great treatments, but they're dying of heart attacks. We also do lots of intervention in terms of improving adherence to treatment and readiness for treatment. More about that later. So I wasn't going to show any slides because I knew you guys would see tons of slides in terms of the fact that we have really fantastic new treatments. But I thought a picture paints 1,000 words. But however, we know that there are a lot of challenges associated with our Hep C treatments as well. And where the multidisciplinary team comes in is helping to deal with those challenges associated with our treatments. And what we know from research is that when we do have a multidisciplinary team, there's much better uptake of treatments and much better success in terms of adherence and long-term outcomes. I was really thrilled that the Ontario Ministry of Health has published guidelines that really describe the important roles and contributions of each team member. So they'll have the role of the physician, the nurse, the social workers, the clinical psychologist. And this is a really important document in terms of advocacy, because people will say, well, in my hospital, we don't have these teams. Well, does your hospital say it's a center for excellence? Because if it does, you can bring these expert guidelines to your hospital administration and say, if we want to be a center for excellence, we have to follow the guidelines. And the guidelines say you need all these different team members. So the social workers can advocate then for their patients to get more social work. The psychologists can advocate. So this is a really important piece of documentation that could be used in other provinces as well. So we know that we have great Hep C treatment successes, but these successes are dependent on patients taking their medications, being adherent to treatments. But what exactly is adherence? So the World Health Organization came up with a pretty straightforward, simple description of what adherence is. It's the extent to which a person's behavior, so adherence is a behavior, such as taking medications, following a diet, or making healthy lifestyle changes, corresponds with agreed upon recommendations from a healthcare provider, period. So it should be straightforward then, you'd think. On the green circle, we have Hep C medications, and in the middle, we have our patient, and depending on their medical status, we'd say, oh, this patient's good for treatment. But of course, as we've heard many times this morning, it's not that simple, because we have all these other circles of factors, all these other social determinants of health, housing, social support, mental health, addiction issues, all of these factors, access to treatment, and as we just heard, stigma are all really important variables that all need to also be taken into consideration when we're making the link between our medications and our patients and their treatment. So then how do we optimally prepare our patients for starting their medications so that they have the best chance possible of doing well on their medications? Well, we've been doing a bit of research, and we can draw from the health psychology research that exists out there. In Ottawa, we've been doing research on adherence and preparedness to treatment in HIV patients for many years now. And we've developed interventions where we basically meet with our patients before they start their HIV medications, and we basically talk to them about what it means for them to start their medications, any misconceptions that they have about their medications. We improve their self-efficacy and their confidence in being able to take their medications, have them feel very much like their treatment is their choice and they're part of the process. And when people go through that process, through 4 sessions of preparation, they're much more likely to be able to be adherent. And this is the case in particular for those at baseline who are depressed. Those who get this intervention, if they at baseline are depressed, become non-depressed and also benefit more from the treatment. We also know from the alcohol literature that using motivational interviewing prior to participating in alcohol intervention reduces patient dropout and improves outcomes. And in the group psychotherapy literature, there's also a large body of evidence that indicates the importance of meeting with your patients before they join a psychotherapy group in order to decrease dropout and improve effectiveness. So we do this a lot. I actually train psychotherapists on how to do pre-group preparation. And the idea is to sit down with your patients before they join the group and demystify what is the process of psychotherapy. Explain to them what they can do in the therapy that makes it work for them. So sharing, being able to be vulnerable in the session, talking about what your issues are, being able to attend regularly, being able to reflect on the process. And we basically have a whole sort of process of what we review with our patients beforehand, and all the group members know that we've reviewed the same information with each of the group members. So we're building universality in their experience before they even join the group. So that helps build group cohesiveness, which is one of the key predictors of positive group outcome. And it also builds trust. And we were just hearing about the importance of trust and therapeutic rapport. That process of really getting people on board with preparing them for their treatment, whether it be a medical treatment or a psychological treatment, is really important. And in terms of medical treatments, there's a big literature that shows if patients are better prepared for their medical surgery, such as knee surgery or their lung surgery, they have less anxiety, more accurate expectations, less pain afterwards, quicker recovery time, and shorter length of hospital stay. We're coming back to that mighty dollar. So the whole idea is you spend a little bit more money beforehand by properly preparing patients, but it's going to cost the system a lot less money afterwards. The same thing applies for chemotherapy treatment as well. Again, by having patients watch a DVD video, having them tour the oncology, desensitize them to the whole process and inform them, they have less side effects as well from their treatment and less fear, less anxiety compared to controls. And those side effects are really important when we think about Hep C treatment. We've heard a lot about the different side effects, in particular at the bottom. I'm a psychologist, the anxiety, depression, irritability. And we know that these side effects can be pretty rough. Actually, that's kind of what my husband says I look like when I'm hungry. I'm not myself when I'm hungry, and it's lunchtime, so just full disclosure there. And it's important here as well to know that helping patients understand as well the time course of the different side effects is also part of the informed decision process that patients make. So readiness for treatment really is about getting patients on board from the very beginning so that they're able to also weigh the pros and cons before deciding to participate in a treatment or not, and feeling that they're much more informed and supported in the process of participating in treatment. I'm not going to go through this slide because we've talked about it a number of times today, but again, the number of people chronically infected versus the number of people who achieve viral clearance, it takes time to achieve that, and there are various barriers along the way. So what are some of the challenges? We've talked about the fact that, and Carla just mentioned the fact that there are barriers at the patient level, the provider level, as well as the structural level. And in the interest of time, I'm not going to spend too much time going over all of those. But at the patient level, we talked about how do we assess our patients. So this is a patient who shows up with his CV, with his resume to his doctor, and his doctor says, well, this is a very impressive resume, young man. I think you're going to make a fine patient. And of course, Baum in 1967 described, of course, how we all expect our patients to walk in. The good patient is the one who establishes immediate rapport, communicates clearly and easily, gives all appropriate data with minimal prompting, is well educated and well read, physically attractive, gets well promptly, is exceedingly grateful, and promptly bolsters our reputation by favorable word of mouth. Of course, that's not the real world, because we're all human beings, and the real world's not quite like that. The real world is more like, so if we are to present a glass of water, the same glass of water in front of a whole bunch of different individuals on the table, or we present the same treatment, the same Hep C treatment in front of all these different people, we're going to get different types of reactions. The first person might say, wow, that glass is half full. That's fantastic. The next person, the glass is half empty. The next person, well, it's half full, half empty, half full, half empty. What was the question? And the next person, hey, I ordered a cheeseburger. So we know that, we have different types of responses from different types of people, and that's really an important piece of diversity in the human experience. So we've got all these different levels where there may be potential barriers to care, and we've talked about these. On the patient level, the fact that they're coming in with a lot of history of isolation, often mental health issues, trauma history. They may not know much about Hep C, or they may have heard a lot about it in the community and have a lot of fears about treatment. At the provider level, we've talked about the fact that often there are a lot of gaps in knowledge. And I was really excited about the ECHO project, and I want to talk more about that, because I think that that's really a wave of the future for us, really to maximize treatment access and treatment knowledge sharing. And also at the structural level, there are a lot of barriers that exist that we've heard about this morning as well. So it's important to say, though, that there are intervention solutions at all levels as well, in terms of education, in terms of using things like case management, incentives, interventions, increasing education levels at all levels, and increasing communication at all levels. And also standardizing so that all people have access to treatment, the right to treatment, and also integration, one-stop shopping care for patients so that they don't have to sort of run around the city trying to gain access to their treatment. And all of this ultimately is good at all levels. In terms of behavioral research, we've heard tons about the amount of exciting drug research that's been done in hepatitis C care, and that's fantastic. What we haven't heard is about what's happening in terms of the behavioral research. It really has not kept pace because we just haven't had the funding yet. And I think that's the next wave, that we also have to now invest in behavioral research to advance Hep C care. What we know, there's some promising research that's already out there that we know that providing psychiatric and substance use treatment increases the rates of Hep C treatment initiation, and that patients who receive treatment for mental health and substance use disorders do as well on Hep C treatment as those without these disorders when adequate treatment support is provided. And so just to highlight again, so several studies that have shown that injection drug users, even current active users, can achieve adherence to Hep C treatment and achieve successful viral clearance, but it's in the context of adequate access to food, housing, medical care, psychiatric care, syringe care, opiate solutions, et cetera, et cetera. So that's the important caveat. So what about readiness for treatment? How do we assess that? Well, we've heard a lot about this morning in terms of what is the medical workup medical workup that needs to be done, and talking about genotype testing, et cetera. What is the psychological workup that needs to be done prior to initiation of treatment? What do we know about that? Because it would be really interesting if we had a systematic way of knowing what the psychosocial predictors were, and then we could do interventions to facilitate adherence and treatment outcomes. So I scoured the literature and saw that. I was really excited because I found this group in New York at the Mount Sinai School of Medicine who are doing this PrEP program. It's psychosocial readiness evaluation preparation for Hep C treatment. And basically, they've standardized a clinical interview and questionnaires that anyone from diverse disciplines can be trained on and used in order to assess a patient's level of psychological readiness to begin Hep C treatment, and the domains to be identified in order to offer treatment interventions. So basically, where this came about is that they looked at the guidelines and they saw, wow, there's fantastic medical guidelines about what the decision needs to be made in terms of medical decision, in terms of viral load, in terms of liver functioning, and all those decisions about what types of Hep C treatments to give. But there are no guidelines for the psychological treatment. And this is where they're in the process of gathering this data, and the data should be presented in the next little while. The results are in process, and it's Dr. Weiss and their colleagues in New York who are doing this. What I was really excited about is that when I looked at all of the different 9 areas of cognitive functioning that they're assessing, I realized this is fantastic because this is what we're doing in Ottawa. So Dr. Curtis Cooper has this huge database we've been collecting in terms of all the psychological measures. So we'll be actually able to, in a parallel way, compare in Canada how, what are some of the psychosocial predictors, what are the cutoff scores on different measures, what types of interventions can we give to help improve the chances that folks can do better on their Hep C treatments and achieve viral clearance. We can't do it alone. It has to be always as part of a team. Teamworks make us strong. And I thank you.